Hello, friends. This is Dr. Vijay, and welcome to the podcast on health and wellness. Last week, we spoke about the breast cancers, the risk factors, and the symptoms associated with breast cancers. We had with us Dr. Rushid Shah and Dr. Praveen Kandelwal. This week, I'll be talking about the investigations once if any of the symptoms are present and if a patient comes with those symptoms. So, the first and the foremost thing when a patient presents with those symptoms after the clinical examination is always a mammogram, which is nothing but a kind of an X-ray, which is confined only to the breasts. So, there are two views, the different views which are usually done in case of a mammogram, but predominantly we see the mammogram, read the mammogram in two different views. So you might also ask me, what is the need of a mammogram when there is a symptom or a lump which is already present? Usually mammograms we call as two different types. One is a screening mammogram and the other one is a diagnostic mammogram. Screening mammogram is particularly done when there is no symptom to the patient, like no lump, no discharge or nothing, but as a matter of a screening program, we keep doing mammograms once yearly or once in 2 years, and also the age also differs depending upon the risk of the patient. So this is screening mammogram. Though the technique is same, the intent is to identify any occult masses when the patient doesn't have any symptoms. Then we term them as a screening mammogram. When a patient comes to us with some symptom and then we are going to do a mammogram, then though in those scenarios we call it as a diagnostic mammogram, though the technique is still the same. This is important. And in case of diagnostic mammogram, when there is a lump already, the intent of doing the mammogram in these scenarios is to know the character of this particular lesion where we are doing the mammogram for, and also additionally we would be seeing the opposite breast as well as the other quadrants of the same breast plus the underarm areas of both the sides. This is particularly important because about few fraction of patients do have breast cancers which are synchronous, that is 2 or 3 areas there may be different foci of breast cancers, maybe in the same breast or maybe in the opposite breast also. So this would allow us to understand if the rest of the breast is normal and if the opposite breast is normal or not, because if at all there is something, we need to address that at the same time. This is mandatory. And after the X-ray mammogram, we need a confirmation. We need a tissue diagnosis, which we term as biopsy. The biopsy is usually done under sono guidance, that is an ultrasound probe would be put on it and then the gun would be inserted and the tissue is taken out. The 3 cores of tissues are removed, which are then sent for histopathological examination under the microscope. Additionally, sometimes if the lump is too huge, then we can directly do a biopsy without a sono guidance also, if it is palpable or if the tumor is very big or something like that. Apart from this, once the confirmation is done, then we need to see the spread of the disease, that is the staging of the disease. So predominantly we divide these breast cancers into 3 different varieties. 1 is an early breast cancer, 2 a locally advanced breast cancer, and 3 a metastatic breast cancer. So in any of these 3 situations, in the histopathological examination, we would be knowing whether the cancer is present or not, if the cancer is present, what grade it is, and then also more importantly, in case of breast cancers, is the receptor status of the disease. We usually see estrogen receptor, progesterone receptor, and the Herceptin receptor status to plan additional treatment with respect to the cancer. Sometimes if we are planning chemotherapy prior to the surgery, which we usually do in case of the locally advanced breast cancers, the second predominant variety which I was talking about, in those scenarios we definitely need to know the receptor status prior to the initiation of chemotherapy. And And also for the staging purpose, in case of early breast cancers where the tumor size is very small, where there is no skin involvement, where there are no lymph nodal involvement, in those scenarios usually we can just get away with a chest x-ray, and even an ultrasound abdomen pelvis is also not mandatory unless the patient has certain symptoms. But practically, routinely, we keep doing ultrasound abdomen and pelvis for almost all the patients irrespective of the consensus, just for the patient's sake, as well as practically speaking that is more easier for us to do also, easily available investigation. Though it is not the indication for early breast cancer. And then in case of locally advanced breast cancers, like if the tumor is very big, or if there is skin involvement, or if there is chest involvement, or if there are lymph nodes which are palpable in the axilla, in those scenarios we also need to know whether the disease has got spread to other areas of the body or not. Predominantly the breast cancer spread to the lungs, liver and the bones. So we usually do blood investigations. Apart from that, we also do a CT of the thorax, CT of the abdomen and pelvis, and also in certain scenarios a bone scan may be required. Or clubbed together, we can directly do a PET CT scan of the whole body to look for any metastasis elsewhere in the body, so that our intent of treatment would change, because locally advanced breast cancers are treated in one way and metastatic breast cancers are treated in a totally different manner. So this is what is about the investigation parts of the breast cancer. Thank you so much.